Hi there, I'm Christina Param-Phillips from Health Academy. Today we are talking about treating B12 deficiency. This is one of our lunchtime update sessions, so welcome. Now's a great time to be having one of these update sessions, as NICE have recently just reviewed their guidelines on treating B12. So a great time to have a look and see at the updates for that. I am an independent nurse prescriber and director of medical skin clinic, but otherwise have no commercial interest to declare. So today we're going to cover many topics, looking at B12, differential diagnosis, how it's given, other things we can do to support our patients, and some of the legal aspects around B12. And introducing it into our practice. So I'm working from a private practice, so my perspective may be a little bit different from those working in an NHS GP practice, for example, but I think it's really interesting to share different perspectives. So first of all, we're looking at the functions of B12. B12 has effects on the energy production in our body, how blood is produced, cells divide, how the brain functions, and the function of the immune system. The BMJ have this great little infographic, so it's well worth looking up if you want a little reminder. So what is B12 deficiency? Well, often B12 deficiency is picked up when patients are anemic. So we often find patients to be anemic when their HB levels are in men over the age of 15 years old, when their HB is less than 130, in women over the age of 15 when it's less than 120, and in pregnant women when it is less than 110. Obviously postpartum we expect HB levels to be a bit lower, but if they're less than 100 then we would be diagnosing them with anemia. So the normal range of HB does vary between different populations, so it's important that we consider that. There's no gold standard as such for measuring B12 deficiency, but we can detect it by measuring the serum cobalamin. Less than 200 nanograms is enough to diagnose 97% of people with a B12 deficiency. But obviously we're looking for clinical correlation too. There's no clear consensus on the level of serum folate levels that indicate deficiency, but less than 3 micrograms is considered the guideline, and a risk for megaloblastic anemia is increased below this level. B12 deficiency can exist without anemia, but the most common cause of it is macrocytic anemia. And I just want to bring your attention here to the new NICE guidelines that have been published in March 6th of March, about diagnosing and managing B12. So signs and symptoms that our patients may come to us with is rapid breathing or shortness of breath, headaches, indigestion, a loss of appetite, palpitations, problems with your vision, feeling weak or tired, diarrhea. There could be cognitive changes, so issues with their memory, understanding, or judgment. They may complain of brain fog, numbness or muscle weakness. There may be changes to their behaviour in terms of depression or anxiety, perhaps problems with balance or coordination. Patients that are presenting with falls, B12 deficiency is something we should be considering. Pins and needles, and an onset of incontinence. Again, this little infographic helps to nicely summarise that for us. The NICE guidelines put particular emphasis in their update with the neurological manifestations and the mental health manifestations, as well as the usual unexplained fatigue and headaches and migraines. We again should be looking if patients have difficulty with their gait or are experiencing falls. B12 is a consideration. If there has been a change in cognition or an onset of dementia, we really need to make sure we're excluding these causes. So causes of B12 deficiency, as we know, pernicious anemia is a very common cause of B12 deficiency. Many drugs can cause B12 deficiency. So most recently, MHRA have released an update, which I think we look at later, about how metformin is particularly common in causing B12 deficiency. So routine screening might be necessary for some of our patients. Gastric disorders, issues that cause malabsorption, and uptake of the B12, inherited issues such as cobalamin mutations and pernicious anemia that we also see in children, nutritional issues such as malnutrition, vegan diet, celiac disease. And we do find that veganism is obviously on the rise now, and we see the fallout of that in terms of B12 deficiencies. So it's important that we're educating our vegan friends about the importance of B12, not just iron, and alcoholism and pancreatic failure. Risk factors include the dietary risk factors, such as vegetarian and vegan diets, potentially patients with eating disorders, and unfortunately in these difficult times we need to consider the socio-economic factors, such as just not being able to afford food that is rich in vitamin B12, and obviously for patients who are leading a vegetarian or vegan diet, for them to have the alternative supplemented fortified foods can be more expensive, and patients with learning difficulties. Prescribed medications we know that can cause a reduced uptake of B12, metformin, PPIs, colchicine, contraceptive pills and antibiotics, anticonvulsants, and the nitrous oxide gas we're seeing is leading to a lot of B12, and this is particularly B12 deficiencies, and this is particularly important in the NICE updates. They've really emphasised this factor. So it is important that we're asking patients about their recreational drug use. Non-dietary risk factors include gastric surgery, terminal ileum resection, increasing age, family history of B12 deficiency, issues such as diabetes or autoimmune conditions, thyroid disease, celiac disease, and abdominal or pelvic radiotherapy. Investigations that we want to consider is a full blood count to determine the mean cell volume, hematocrit and the HB levels, and a blood film which will help us to identify megablastic anemia. We want to be measuring the serum cobalamin and folate levels to determine the cause of the anemia, and any additional investigations such as liver function tests, thyroid tests, anything that we think may be contributing to this. The NICE guidelines in terms of an update have emphasised obviously our diagnostic tests and the test for diagnosing the cause. It's important that we get to the root of that. What else could it be? So lead toxicity could be one of our differential diagnosis, syphilis, HIV, MS, other deficiencies, and use of alcohol, drugs, any hematological abnormalities, liver disease, pregnancy, and sort of the postpartum period, severe thyroid deficiency or smoking. How are we treating our patients with vitamin B12 deficiency anemia? If there is neurological involvement, it's important that we seek specialist advice. We want to be referring them to a neurologist or haematologist. Ideally, management should be guided by a specialist, but if we can't access that specialist advice immediately, we want to administer 1 milligram of cobalamin intramuscularly on alternate days until they stop seeing an improvement in their symptoms. So once we've got to their sort of improved state, we then maintain with 1 milligram of cobalamin once every 2 months via an IM injection. Hopefully they will then get to see a neurologist or haematologist who can work out what the root cause is if we've been unable to do so in the meantime. For people with no neurological involvement, you want to initially administer 1 milligram of cobalamin intramuscularly 3 times a week for 2 weeks, and then the maintenance dose will very much depend on the patient. So if the deficiency is diet related and that's something that can be corrected, that's great. If it's not diet related, we want to administer 1 milligram of cobalamin intramuscularly every 2 to 3 months, and that is likely to be a lifetime treatment. Alternatively, a large oral dose can work for some patients. If it is thought to be diet related, we want to advise people to either take an oral supplement between meals or have the twice monthly injection. In vegans, treatment may be lifelong, whereas some others it may be that we can get them back to optimal levels and then they can manage that with their diet or supplement. In terms of the intramuscular treatment, we want to start the 1000 micrograms on alternate days, and then if there are neurological symptoms involved, continue the B12 IM injections on alternate days until the symptoms have subsided and don't improve any further, and then slowly reduce the frequency. If it's anemia only, then we want to gradually reduce that injection frequency after 2 to 5 weeks, and then maintain that with an injection every 1 to 2 months. In terms of interventions, our NICE updates tell us that we are looking at the hydroxycobalamin intramuscular or subcutaneous injection. It's not licensed for subcutaneous injection, but some patients do find this preferable, so it is an alternative. The cyanocobalamin we can give as oral tablets, as IM injection, or as a subcut injection. We want to be giving our patients dietary advice, and if it's reasonable to do so, consider the drugs that they are on and if there's any changes we could make to those drugs which would reduce their risk of B12 deficiency in the future. And then looking at the other hematological values. So this is a video from Health Academy on the injection of vaccinations, but I think it's a good one to show you the technique for administering a B12 injection.
Wash your hands or use hand sanitizing gel. Get your patient into the most suitable position. For patients 1 year or older, the preferred vaccine site is the deltoid. Ask them to expose the whole of their arm, locate the centre of the deltoid muscle, and ask for them to relax their arm. In most cases, the vaccine will be administered intramuscularly following these procedures. Stretch the skin over the muscle. Insert the needle at a 90 degrees angle. Do not aspirate the syringe. Administer the full dose of the vaccine and remove the needle. Apply pressure with gauze or cotton wool over the site. Dispose of the needle into a sharps container immediately. Stretch the skin over the muscle. Insert the needle at a 90 degrees angle. Administer the full dose of the vaccine and remove the needle. Dispose of the needle into a sharps container immediately. Observe the patient for any immediate adverse reactions whilst completing your medical records. The minimum information that should be recorded is the product name, batch number and expiry date, the dose administered, the site of administration, the date of administration, and the name and signature or digital confirmation of the administering clinician. There are very few circumstances where the flu vaccine should be administered using a subcutaneous technique. Where a subcutaneous technique is required, bunch the skin, insert the needle at a 45-degree angle, do not aspirate the syringe, administer the full dose and remove syringe. Apply pressure over the site of the vaccine. Dispose of the needle into a sharps container immediately.
So, contraindications to treatment. You should not use vitamin B12 if you're allergic to cyanocobalamin or cobalt. Cobalt isn't an allergy we frequently think of, so an important one to ask about. And if the patient has Leber's disease, cyanocobalamin can lead to optical nerve damage and even blindness in patients with Leber's disease, so that's really important. Make sure we're always checking our SPC for contraindications and any special warnings to ensure that we are up to date with that. Dietary support. It's important that we support patients to understand the need for B12 in their diet. In adults aged 19 to 64, they need 1.5 micrograms a day of B12. It's readily available in eggs, milk and cheese. But for our vegan and vegetarian friends, we want to make sure that they're having fortified oat, rice or soy milks and fortified yogurts, alternatives or spreads or yeast extract. People who are vegan should aim to include foods that are fortified at least 3 times a day. If these foods aren't consumed in adequate amounts, then they recommend that a B12 supplement be purchased from a pharmacy. Meat is a great source of B12, particularly beef, lamb and pork. And liver pate also has B12 readily available, but we should note that pregnant women shouldn't be advised to eat liver or liver pate. And fish, fortified breakfast cereals and Marmite are also good sources of B12. So when should you refer a person with B12 deficiency or a folate deficiency anemia? If that person has neurological symptoms or is pregnant, you want to refer to a haematologist. If the cause of the B12 or folate deficiency is uncertain, or if you're unclear following investigations, if you suspect a haematological malignancy or other blood disorder, if the person does not respond to treatment, or if the mean cell volume is persistently greater than 105 femilitres. If we are suspecting a haematological malignancy or other blood disorder, we want to use the 2-week wait. We should be referring patients to a gastroenterologist if we suspect malabsorption or inflammatory bowel disorder is suspected, or if the person has pernicious anemia and gastrointestinal symptoms, particularly if there is a suspicion of gastric cancer, in which case obviously we would refer on the 2-week wait. And consider a referral to a dietitian if the B12 deficiency or the folate deficiency is thought to be related to poor diet or a vegan or vegetarian diet that the patient feels they are unable to. So what monitoring is required after treatment for B12 or folate deficiency has started? We want to perform a full blood count within 7 to 10 days of starting treatment. We're looking to see a rise in the hemoglobin level and for it to become within normal range. We know that the treatment is having a positive effect. If there's no improvement at all following the initial B12 treatment, then we want to be checking the serum folate levels if we've not done this already. After 8 weeks, we want our blood counts and mean cell volume to have normalised. If this isn't the case, then we want to be considering other causes of the B12 or folate deficiency. At this point, we should also measure the iron and folate levels to ensure that other deficiencies haven't been masked. And then we want to be performing another blood count on completion of the folic acid treatment to confirm a response. Measuring cobalamin levels is unhelpful as levels increase with treatment, even regardless of how effective the treatment is. But we can check the cobalamin 1 to 2 months after starting the treatment, and if there's no response, we want to be considering alternative treatment routes. Neurological recovery time can take some time. Improvement begins within 1 week and can take 6 weeks to 3 months to fully improve. And ongoing monitoring is necessary unless the lack of compliance is an issue, or if the anemia does not improve. We must be mindful that patients can function with low levels of B12 for up to 5 years. Our bodies actually store B12 for up to 5 years. So we might be looking at a historical reduction in B12 intake or health issue that has caused this. So just bear that in mind. It's not necessarily that the patient will become vegan and sort of suffer within a short space of time. It may be from a while back. Prevention, this is largely to do with our dietary intake. So if our intake is adequate, we shouldn't have a deficiency unless there is other issues causing that. Oral supplementation, 20 to 50 micrograms can help to prevent B12 deficiency. Following up on our treatment, we should be monitoring the patient and be alert for other deficiencies. So B2, folate, iron and D3 are common ones. Long-term maintenance may vary from twice a week to once every 4 weeks. So make sure that we're individualising our treatment plan for our patient. And if possible, teach self-administration to the patient. If they're willing, it can be very empowering and helps them to ensure that they're getting their treatment on time. Now, do I need to be CQC regulated? This is a question that is very commonly asked, particularly as we're seeing B12 injections being given in non-medical settings or in sort of private clinics. Yes is the answer. The CQC regulate the activity, and this activity is a CQC related activity. It falls under treatment of disease, disorder or injury. And do I need to be a healthcare professional? Again, the answer is yes. Hydroxycobalamin is a prescription-only medication and should be prescribed by a doctor or nurse. May be delegated to a competent healthcare professional for administration, not to a non-healthcare professional. It may be given under a legal framework of delegation, such as a PGD or a PSD. Your local guidelines will alert you if that is in place. The CQC have the power to prosecute health and social care providers in England. They do this if they believe the provider is failing to give safe, high quality care and think this is intentional or unavoidable. They can prosecute both organisations and individuals. They can prosecute individuals who are healthcare professionals, and they can also prosecute individuals who are not healthcare professionals. It is incorrect to believe that the CQC only regulate healthcare professionals. And there have been cases where some non-healthcare professional people were running fetal scanning services, ultrasound clinics, and they were prosecuted. So yes, absolutely, if we are administering B12 injections, and we should be monitoring the patient, this is a diagnosis that needs to be given and managed by a healthcare professional. Relevant safety updates from MHRA. We had one in December 2022, which considered that metformin treatment is a very high risk treatment for vitamin B12 deficiency. So therefore it's considered that patients should be routinely checked and monitored for B12 deficiency if they're on metformin. And the medicines used to treat B12 deficiency, the hydroxycobalamin and the cyanocobalamin, contain cobalt. So there's careful consideration to patients who have a cobalt allergy, which, as we discussed earlier, isn't necessarily one we will think of to ask, or they will think of to tell us. So if we're looking to initiate B12 treatment, just bear that in mind. One thing that's often said about B12 is you can't give too much, they will just pee out the excess. And this is often quoted by sort of private clinics or non-healthcare professionals that are administering B12 for the argument that patients can just have essentially as many as they like and it doesn't need to be monitored. Well, the NHS say of this that there is not enough evidence to show what the effects may be of taking high doses of vitamin B12 supplements every day. So the Department of Health and Social Care advise that you should be able to get the dose you need of B12 from eating a varied and balanced diet. If you take B12 supplements, do not take too much, as it could be harmful, and taking 2 milligrams or less of vitamin B12 in supplements is unlikely to cause any harm. However, taking regular injections of B12 or high doses of oral B12, we can't rule out that this would be harmful. Whilst it is a water-soluble vitamin, which leads us to believe that they will pee out the excess. We don't know the consequence for the body of having to deal with high levels of B12. So it is important that patients are monitored. Interestingly, I've had one of my colleagues who works in a GP practice contact me recently to say that they've noticed since a beauty outfit has started round the corner giving out B12 injections, that their patients are frequently presenting with very high levels of B12 in sort of excess of 2,000 to 3,000 levels showing on their blood. So they are now looking at how they can move this forward to protect their patients, because they are concerned about the potential risk to their patients. What I would say is, if you experience this in your own practice, do audit it, because it's the government are looking to introduce much more regulation into this area, particularly amongst non-healthcare professionals and private clinics, but it really supports them if they have the data. So please, if you're noticing patients with excessive levels of B12, if they're stating that they're getting treated elsewhere and you're concerned, please do audit this in your practice. We've got some legal case examples of patients where B12 deficiencies have not been noticed. So in our first example, and this was just from one particular solicitor, we had a lady, Charlotte Hayward. She had a delayed diagnosis which resulted in irreversible effects to her mobility and her vision. She had the Health and Social Care Act 2008, Regulation 13, states that registered person must protect service users against risks associated with unsafe use of management of medicines by means of making appropriate arrangements for obtaining, recording, handling, using, safekeeping, dispensing, safe administration and disposal of medicines used for the purposes of the regulated activity. In making the arrangements referred to in paragraph 1, the registered person must have regard to any guidance issued by the Secretary of State or appropriate expert body in relation to the safe handling and use of medicines. So when we are prescribing B12, we want to ensure that we are, as the previous slide said, delegating to suitably trained healthcare professionals. It's not okay to delegate to non-healthcare professionals, and it is our responsibility for the full process. Regulation 11 tells us that if the service user is 16 or over, and is unable to give consent because they lack capacity, the registered person must act in accordance with the Mental Capacity Act. And if Part 4 or 4A of the Mental Health Act applies to the service user, the registered person must act in accordance with the provisions of the Act. essentially we need to make sure that we have proper consent, and we know that consent regulations have changed recently, which means that the onus is on us to make sure that patients not only are aware of the risks and side effects before agreeing to having treatment, but really understand what it is we are doing. So it's a good idea to ask your patients to repeat back to you what you've told them the treatment is, what it's for, the intended benefits and risks and side effects. Other considerations, if we are looking at offering this treatment in our practice, is the storage, distribution and disposal of medicines. The Green Book here refers to vaccines, but B12 is to be treated in very much the same way in terms of storage, distribution and disposal. We should have an anaphylaxis protocol, and we should be up to date with this, making sure we're attending our mandatory training sessions on an annual basis, but actually in person we should be attending this training at least every 3 years. Just doing it online isn't good enough. We should be having hands-on experience with our sort of anaphylactic training and our CPR training. Medicines management, the CQC give us guidance on this, and the yellow card scheme about how we should be reporting any adverse effects as a result of giving B12 injections, and this will include our allergic responses, any anaphylactic responses and any other side effects the patients may have. And then we have guidance on our patient group directives and patient-specific group directives, if we're looking at developing that as a way of administering B12 B12 injections within our practice. So in order for us to stay up to date, we should sign up to the MHRA notices that they just pop the drug device alert straight into your inbox, so you can see what's the latest news in that respect. Sign up for the UK health security updates, and again that will be any particular threats to public health we'll be notified of. We should be reviewing our NICE guidelines, regulatory guidelines and local policies every 6 months, and if we are responsible for our own policies, then we should be reviewing those, or our employers should be reviewing those every 6 months to make sure that our practice is evidence-based and up to date. We should be auditing our clinical outcomes to make sure that we are working in line with guidelines, and we are getting the best results for our patients. And as we mentioned before, we should be updating our mandatory training annually and attending in person every 3 years. So that is the end of our lunchtime update on B12. Thank you very much for your attention. Health Academy offers a wide range of courses. They offer a Vitamin B12 Deficiency training, immunisation training and phlebotomy training, which will all help to support our practice in administering B12. They have many more courses as well, and they offer both online and in-person courses. It's worth being aware of the Primary Care Convention, which is on Saturday the 15th of June. There is a early bird rate at the moment for £95, so I'd really recommend that you jump ahead and book your tickets now. There's tickets left, I believe, and once this early bird rate is over, tickets will be £130. So grab those last few tickets whilst you can. Lunch is included, always a bonus, and it runs from 9:30 until 4:30. And there's a great overview of many of the issues we see in primary care. So well worth a visit. So thank you very much for your kind attention, and I hope that was helpful to you.